Ulcerative colitis. Etiology. It is a type of inflammatory bowel disease that disrupts the mucosal lining of the rectum and colon, resulting in recurrent episodes of abdominal pain and bloody diarrhea. By definition, the inflammation in ulcerative colitis involves the rectum and ascends continuously through the colon, sparing the small intestine. Ulcerative colitis is slightly more common in men and occurs more frequently in Caucasians when compared to other races. There is also a bimodal age distribution that peaks between 15 to 25 years of age, then again between 55 to 65 years of age. Both ulcerative colitis and Crohn's disease are more common in women who use oral contraceptive pills. Ulcerative colitis occurs more commonly in developed countries. The exact etiology of ulcerative colitis is still unknown, but it has been linked to genetic factors, that is, a family history of ulcerative colitis. Immune system reactions, most frequently the presence of paranuclear anti-neutrophil cytoplasmic antibodies. Environmental factors. Non-steroidal anti-inflammatory drug use, associated with HLA-DR2 and HLA-B27. Interleukin-10 gene polymorphism is associated with ulcerative colitis. CD4 Th2 cells are also involved. Protective factors. Smoking is a protective factor, and patients who have had an appendectomy appear to be at a decreased risk for developing ulcerative colitis. Clinical features. Clinical features of ulcerative colitis include hematochezia, bloody diarrhea, rectal mucus discharge, tenesmus, sensation of incomplete defecation, feeling of needing to evacuate the bowels frequently, fecal incontinence, colicky abdominal pain, frequent small volume bowel movements. The onset of symptoms is usually gradual, and symptoms are progressive over several weeks. Symptoms may be preceded by a self-limited episode of rectal bleeding that occurred weeks or months earlier. Patients may have systemic symptoms including fever, fatigue, and weight loss. Patients may also have dyspnea and palpitations due to anemia secondary to iron deficiency from blood loss, anemia of chronic disease, or autoimmune hemolytic anemia. Extraintestinal manifestations. Various extraintestinal symptoms have also been associated with ulcerative colitis, such as uveitis, inflammation of the middle layer of the eye. Episcleritis. It's an inflammatory condition affecting the episcleral tissue between the conjunctiva and the sclera that occurs in the absence of an infection. Pyoderma gangrenosum, necrotic ulcerations of the legs. Ankylosing spondylitis, chronic inflammation of the spine. Primary sclerosing cholangitis, sclerosis of both intrahepatic and extrahepatic bile ducts. Primary sclerosing cholangitis is a biliary disease that causes fibrosis of the biliary tree. This condition is more typically associated with ulcerative colitis but can occur in Crohn's disease as well. Disease severity. The Montreal classification of severity of ulcerative colitis is one such index that stratifies ulcerative colitis severity into mild, moderate, and severe, based on the frequency and severity of diarrhea and the presence of systemic symptoms and laboratory abnormalities. Patients with mild clinical disease have 4 or fewer stools per day with or without blood, no signs of systemic toxicity, and a normal erythrocyte sedimentation rate. Mild crampy pain, tenesmus, and periods of constipation are also common, but mild abdominal pain, profuse bleeding, fever, and weight loss are not part of the spectrum of mild disease. Patients with the moderate clinical disease have frequent loose, bloody stools, greater than 4 per day, mild anemia not requiring blood transfusions, and abdominal pain that is not severe. Patients have minimal signs of systemic toxicity, including a low-grade fever. Adequate nutrition is usually maintained, and weight loss is not associated with moderate clinical disease. Patients with a severe clinical presentation typically have frequent loose, bloody stools, greater than or equal to 6 per day, with severe cramps and evidence of systemic toxicity as demonstrated by fever, temperature greater than or equal to 37.5 degrees centigrade, tachycardia, heart rate greater than or equal to 90 beats per minute, anemia, hemoglobin less than 10.5 grams per deciliter, or an elevated erythrocyte sedimentation rate greater than or equal to 30 millimeters per hour, Patients may have rapid weight loss. Note: the Mayo scoring system can also be used to assess disease severity and monitor patients during therapy. Scores range from 0 to 12, with higher scores indicating more severe disease. Classification of ulcerative colitis by disease extent. The extent of the disease is classified based on endoscopic findings. Montreal classification for the extent of ulcerative colitis. Disease extent and mucosal involvement, limited to the rectum. Ulcerative proctitis, E1. Left-sided ulcerative colitis, E2. Limited to the colon distal to the splenic flexure. Extensive ulcerative colitis, E3. Extends proximal to the splenic flexure. Disease course. Chronic intermittent course. It's the most common course. Exacerbation is followed by complete remission. Chronic continuous course. Complete remission does not occur, and disease severity varies. Acute fulminant course. It is sudden onset and characterized by severe diarrhea, dehydration, shock. Pathology. Major pathologic process involves mucosa and submucosa of the colon, with sparing of the muscularis. Typical gross appearance. Hyperemic mucosa, in which mucosa is reddened, granular, and friable with inflammatory pseudopolyps, which are diffusely distributed. There can be extensive ulceration or atrophic and flattened mucosa with no skip lesions. Rectal involvement, proctitis, is the hallmark of the disease, and diagnosis should be seriously questioned if the rectal mucosa is not affected. Mucosal inflammation is up to mucosa only. Crypt abscesses and ulcers are observed with T helper 2 lymphoid aggregates. Chronic mucosal damage, glandular architectural distortion, and atrophy are characteristic. Pathophysiology. The exact mechanism is unknown, but studies suggest that ulcerative colitis is caused by abnormal interactions between host immune cells and commensal bacteria. Dysregulation at the epithelial barrier. Alterations in intestinal mucus, high numbers of bacteria within the mucus, and increased intestinal permeability have been associated with inflammatory bowel disease. Increased permeability for luminal bacteria causes activation of macrophages and dendritic cells. Antigen presenting to macrophages and naive CD4+ cells lead to secretion of pro-inflammatory cytokines, for example, interleukin-6, interleukin-12, tumor necrosis factor alpha, and chemokines, like chemokine ligand 1, chemokine ligand 3, and chemokine ligand 8, causing the recruitment of other immune cells, for example, neutrophils, to the site. Differentiation of naive CD4+ cells to T helper 2 effector cells, and recruitment of natural killer cells. Dysregulation in immune cells. Upregulation of lymphatic cell activity, T cells, B cells, plasma cells, and bowel walls, causes enhanced immune reaction and cytotoxic effect on colonic epithelium, leading to inflammation with local tissue damage, like ulcerations, erosions, and necrosis in the submucosa and mucosa. Role of microbes. The distal ileum and colon contain high concentration of microbes. Bidirectional host microbe interactions in the intestine can be mutually beneficial or have adverse effects that contribute to intestinal inflammation. Diagnosis. The diagnostic modality of choice for ulcerative colitis is colonoscopy with mucosal biopsy. Colonoscopy will typically show a friable erythematous mucosa with or without ulcerations and pseudopolyps that extends continuously from the rectum to part of or the entire colon. Biopsy typically reveals inflammation limited to the mucosa, submucosa, and crypt abscesses. The inflammation is not transmural. Biopsies of the colon obtained on endoscopy are necessary to establish the chronicity of inflammation and to exclude other causes of colitis. Imaging is typically not required for diagnosing ulcerative colitis, but plain upright X-rays can help diagnose toxic megacolon or colonic perforation in the acute setting. Endoscopic findings in patients with ulcerative colitis are nonspecific. The endoscopic findings in patients with ulcerative colitis include a loss of vascular markings due to engorgement of the mucosa, giving it an erythematous appearance. In addition, the granularity of the mucosa, petechiae, exudates, edema, erosions, touch friability, and spontaneous bleeding may be present. More severe cases may be associated with macro-ulcerations, profuse bleeding, and copious exudates. Double contrast barium enema can be used if ulcerative colitis is suspected, but should be avoided during an acute attack due to the risk of perforation. Characteristic findings on barium enema include micro-ulcerations, pseudopolyps, narrowing of the luminal wall, and loss of haustra, giving lead pipe appearance. Note: diagnostic characteristic of ulcerative colitis is continuous uninterrupted inflammation of the mucosa, beginning in the distal rectum and extending proximally to a variable distance. Laboratory findings. Patients with severe ulcerative colitis may have anemia, an elevated erythrocyte sedimentation rate greater than or equal to 30 millimeters per hour, low albumin, and electrolyte abnormalities due to diarrhea and dehydration. Patients with ulcerative colitis and primary sclerosing cholangitis may have an elevation in serum alkaline phosphatase concentration. Paranuclear anti-neutrophil cytoplasmic antibodies is having 92% specificity for ulcerative colitis. Fecal calprotectin or lactoferrin may be elevated due to intestinal inflammation but are nonspecific. Fecal lactoferrin is a highly sensitive and specific marker for detecting intestinal inflammation. Both fecal lactoferrin and calprotectin are an integral part of management to rule out active inflammation versus symptoms of irritable bowel or bacterial overgrowth. Medical management of low-risk adult patients with mild to moderate ulcerative colitis. Ulcerative proctitis or proctosigmoiditis. Initial therapy. Topical mesalamine is the first-line treatment for inducing remission in low-risk patients with mild to moderate ulcerative proctitis or proctosigmoiditis. Mesalamine is widely available in two forms: suppository or enema. Alternative therapy. Alternative agents are available as initial therapy for patients with a hypersensitivity to topical mesalamine or for patients who are unable or unwilling to use topical therapies in general. Topical glucocorticoids. Patients who can't tolerate topical mesalamine but who can use rectal therapy are treated with topical glucocorticoids, and the formulation depends on disease extent. For example, hydrocortisone, budesonide. Oral 5-amino-salicylic acid agents. Patients who are unwilling or unable to tolerate topical medications can be treated with an oral 5-amino-salicylic acid medication. It's preferable, to begin with, high-dose mesalamine, that is more than 3 grams daily. Sulfasalazine, 4 grams daily, is an alternative option, especially in patients with inflammatory bowel disease-associated arthritis. Maintenance of remission. For patients with ulcerative proctitis who responded well to topical mesalamine for induction of remission and who have more than one flare per year, it is advised to use a maintenance regimen of 1 mesalamine suppository, 1 gram, every night. For patients with ulcerative proctosigmoiditis who responded well to topical mesalamine for induction of remission, using a maintenance regimen of 1 mesalamine enema every night is recommended. For patients who required an oral 5-amino-salicylic acid agent to achieve remission, it's better to continue oral amino-salicylic acid therapy to maintain remission. Left-sided or extensive colitis. Initial therapy. We use a combination of an oral 5-amino-salicylic acid agent plus rectal mesalamine for patients with left-sided or extensive, mildly to moderately active ulcerative colitis. Symptomatic improvement is usually seen within 2 to 4 weeks. It's preferred to begin high-dose mesalamine, that is more than 3 grams daily, as the initial oral therapy for patients with left-sided colitis or extensive colitis. Sulfasalazine, 4 grams per day, is an alternative option. Oral 5-amino-salicylic acid agent plus topical, rectal, glucocorticoids. For patients who do not respond to combination therapy, topical mesalamine can be replaced with topical glucocorticoid therapy, for example, hydrocortisone, budesonide, enema, foam, or suppository daily, while the oral 5-amino-salicylic acid agents are continued. Maintenance of remission. Oral 5-amino-salicylic acid agents and/or topical mesalamine formulations are used to maintain remission in patients with left-sided or extensive, mild to moderate ulcerative colitis. Both systemic, for example prednisone, and locally acting, for example budesonide multimatrix glucocorticoids, are not used for maintenance therapy because of the lack of efficacy data and the risk of adverse effects. Monitoring during remission. It's recommended to assess patients clinically and with colonoscopy in 6 to 12 months after achieving clinical remission at the time of colonoscopy and correlates these tests with the degree of mucosal healing. In addition, non-invasive markers of inflammation can be useful. Inflammatory markers assessment includes C-reactive protein and fecal calprotectin. Management of moderate to severe ulcerative colitis in adults. Induction of remission. For the patient with moderate to severe ulcerative colitis, first-line induction therapy options include biologic agents with or without an immunomodulator, for example, azathioprine or glucocorticoids. Induction regimen of choice is infliximab combined with azathioprine for most patients who have failed other biologic therapies, for example, vedolizumab, who are not compliant with self-injections, for example, adalimumab. Vedolizumab is the preferred induction therapy for most patients who are greater than or equal to 65 years old or who have a history of recent infection, for example, pneumonia, within the previous 3 months, because vedolizumab is not associated with an increased risk of serious infection. Anti-tumor necrosis factor agent-based therapy, with or without an immunomodulator, for example, azathioprine, is used to induce remission in patients with moderate to severe ulcerative colitis. For patients who do not tolerate thiopurines, azathioprine or 6-mercaptopurine, methotrexate is an alternative immunomodulator. Ustekinumab. Ustekinumab, an anti-interleukin 12-23 antibody, was approved by United States Food and Drug Administration for the treatment of moderate to severe ulcerative colitis in 2019. Ustekinumab may be used as a first-line biologic therapy for some patients, for example, those who have not responded to other therapies, that is, mesalamine and/or glucocorticoids and/or immunosuppressants. Failure to respond to an anti-tumor necrosis factor agent is not required prior to using ustekinumab. Glucocorticoids. Systemic oral glucocorticoids, oral prednisone at a dose of 40 mg daily, are used for inducing remission in patients with moderate to severe ulcerative colitis or may be given to provide more immediate symptom relief for patients who are started on a biologic agent for induction therapy. Glucocorticoids should not be used long-term because of the side effect profile and also because they're not used for maintaining disease remission. After clinical remission has been achieved, that is, formed stools, no blood, it's recommended to taper prednisone by either 5 mg or 10 mg increments on a weekly or semi-weekly basis. Janus kinase inhibitors. 2 oral Janus kinase inhibitors, tofacitinib and upadacitinib, are approved in the United States for treating adults with moderate to severe ulcerative colitis who have not responded or are intolerant to anti-tumor necrosis factor agent-based therapy. Caution should be used when prescribing Janus kinase inhibitors for patients with a history of thromboembolic disease, cardiovascular disease, or those greater than or equal to 50 years old. Prior to initiating Janus kinase inhibitors or shortly after starting therapy, give the non-live recombinant zoster shingles vaccine to adult patients with evidence of immunity to varicella because Janus kinase inhibitors are associated with higher rates of herpes zoster infection. Ozanimod. Ozanimod is an oral sphingosine 1-phosphate receptor modulator that is used for treating adult patients with moderate to severe ulcerative colitis. Ozanimod use does not require the previous failure of immunosuppressants, glucocorticoids, biologics, or other small molecules. Ozanimod is effective in inducing remission for patients with ulcerative colitis. Maintenance of remission. Anti-tumor necrosis factor agent-induced remission. For patients who achieved clinical and endoscopic remission with an anti-tumor necrosis factor-based regimen, the best approach to maintenance therapy is as follows. For patients on combination therapy, anti-tumor necrosis factor agent plus an immunomodulator, it is advised to continue long-term anti-tumor necrosis factor therapy. For patients on anti-tumor necrosis factor monotherapy, better to continue long-term anti-tumor necrosis factor therapy to maintain remission. Anti-tumor necrosis factor agents were effective in maintaining remission for patients with ulcerative colitis who achieved remission with an anti-tumor necrosis factor agent. Vedolizumab-induced remission. For patients who achieved remission with vedolizumab, we continue long-term vedolizumab therapy to maintain remission. Ustekinumab-induced remission. For patients who achieve remission with ustekinumab, it is continued for long-term maintenance therapy. Glucocorticoid-induced remission. Glucocorticoids are not used for maintaining remission in ulcerative colitis and should be tapered while a thiopurine, for example azathioprine, is initiated for long-term therapy. Alternatively, a biologic agent, for example anti-tumor necrosis factor agent, may be used as long-term maintenance therapy for patients who achieved remission with glucocorticoid monotherapy. Management of the hospitalized adult patient with severe ulcerative colitis. Defining disease severity. In clinical practice, acute severe ulcerative colitis can be defined by the following: bloody stool frequency greater than or equal to 6 per day, plus at least one of the following, that is, evidence of systemic toxicity: fever, temperature greater than or equal to 37.8 degrees Celsius, tachycardia, heart rate greater than or equal to 90 beats per minute, anemia, hemoglobin less than 10.5 grams per deciliter, 105 grams per liter, elevated inflammatory marker, for example, C-reactive protein. Inpatient management. Patients with acute severe ulcerative colitis are managed with inpatient hospitalization, monitoring, fluid, and electrolyte replacement, and they may require blood products. Initial therapy. For patients with acute severe ulcerative colitis, it is recommended that intravenous glucocorticoid therapy as an initial treatment to induce remission. Topical glucocorticoids can also be given because topical treatment may provide symptomatic relief, for example, reduced fecal urgency, tenesmus. Escalating medical therapy. For patients with acute severe ulcerative colitis who fail to respond to intravenous glucocorticoid therapy in 5 days, initiate second-line therapy with either infliximab or cyclosporin. Maintaining remission. For patients with acute severe ulcerative colitis who achieve clinical remission with medical therapy, it is suggested to use long-term medical therapy for maintaining remission. Commonly used maintenance therapy regimens include an anti-tumor necrosis factor agent with a thiopurine, anti-tumor necrosis factor agent monotherapy, or thiopurine monotherapy. Surgical management of ulcerative colitis. Surgical management of ulcerative colitis is required when patients fail medical therapy or when serious complications arise. Emergency surgery is indicated in patients with colonic perforation, life-threatening gastrointestinal hemorrhage, or toxic megacolon. A total abdominal colectomy with an ileostomy is the procedure of choice in both situations. This procedure removes the entire colon, but leaves behind a defunctionalized rectum as Hartmann's pouch. It's a simple procedure that can be performed quickly and is favored in an emergency or in urgent situations. Total proctocolectomy with an ileostomy. A total proctocolectomy with an ileostomy removes the entire colon and rectum without reestablishing gastrointestinal continuity. The end ileostomy is permanent and can be constructed in a continent, cock, or incontinent brook fashion. A total proctocolectomy with permanent ileostomy is curative for ulcerative colitis and can be performed laparoscopically as a scarless or incisionless procedure. Elective surgery is indicated in patients with persistent symptoms despite the best medical management and in those with increased cancer risk. For patients who are medically ill, for example, older patients, significant comorbid disease, concurrent rectal cancer, a proctocolectomy with an ileostomy is the best surgical option. Most patients undergo a restorative proctocolectomy with ileal pouch anal anastomosis. Restorative proctocolectomy with ileal pouch anal anastomosis has become the most common definitive operation for the surgical treatment of ulcerative colitis. Complications of ulcerative colitis include increased risk of colorectal cancer. The risk begins 8 to 10 years after the initial diagnosis of pancolitis and 12 to 15 years after the onset of left-sided colitis. At this point in time, colonoscopies every 1 to 2 years with biopsies for dysplasia are recommended. Severe bleeding. Bleeding may be severe in up to 10% of patients. Massive hemorrhage occurs in up to 3% of patients with ulcerative colitis at some time in their disease course and may necessitate urgent colectomy. Strictures. Colonic perforation. Perforation of the colon most commonly occurs as a consequence of toxic megacolon. Fulminant colitis. Patients with ulcerative colitis may develop fulminant colitis with more than 10 stools per day, continuous bleeding, abdominal pain, distension, and acute severe toxic symptoms, including fever and anorexia. Patients with fulminant colitis are at high risk of developing toxic megacolon as the inflammatory process extends beyond the mucosa to involve the muscle layers of the colon. Toxic megacolon. Patients with ulcerative colitis are at the greatest risk of developing toxic megacolon early in the course of the disease, within 3 years of diagnosis. Plain abdominal radiographs in patients with toxic megacolon classically reveal thick haustral markings that do not extend across the entire lumen. Vital signs in labs indicative of toxic megacolon include fever greater than 38 degrees centigrade, heart rate greater than 120 beats per minute, neutrophilic leukocytosis greater than 10,500 per microliter, anemia, hypotension. Here's a table differentiating ulcerative colitis from Crohn's disease. Disease distribution. Ulcerative colitis commonly affects the colon and rectum, whereas in Crohn's disease commonly affects the terminal ileum or may involve any part of the gastrointestinal tract, that is, mouth to rectum. Skip lesions, that is, spatially intermittent bowel inflammation, are rare in ulcerative colitis and common in Crohn's disease. Vascularity of the mucosa is friable mucosa with loss of vascularity in ulcerative colitis and in Crohn's disease, normal vasculature adjacent to inflamed mucosa. Ulceration is mainly mucosal and transmural only in severe colitis. In Crohn's disease, aphthous ulcers, these are small discrete mucosal ulcers. Transmural ulcers are deeper ulcers that involve the colon wall. Cobblestone appearance, not seen in ulcerative colitis, common in Crohn's disease. Stricture, rare in ulcerative colitis, common in Crohn's disease. Fistula, rare in ulcerative colitis, common in Crohn's disease. For example, perianal, enterocutaneous, or rectovaginal fistula. Perianal disease, rare in ulcerative colitis, common in Crohn's disease. For example, perianal fistula or deep anal fissure. Image-based discussion. Here's an image of diversion pouchitis with severe edema, friability, and hemorrhage of the pouch mucosa. This endoscopic image from a patient with ulcerative colitis demonstrates multiple pseudopolyps. Double contrast barium enema demonstrates extensive mucosal ulceration and inflammation throughout the colon. Double contrast barium enema demonstrates mucosal pseudopolyps and a stricture arising in the descending colon. Double contrast barium enema shows fine linear polyps arising from the colon wall. These polyps are typically seen in chronic ulcerative colitis. Double contrast barium enema in a patient with chronic ulcerative colitis shows a featureless colon with complete loss of folds in the sigmoid colon. Transabdominal ultrasound of chronic active ulcerative colitis on the sigmoid colon showing a symmetric mural inflammatory reaction by color Doppler imaging, bowel wall thickening of the mucosa, echo-rich and hypervascular submucosa, and echopore muscularis propria is indicated. The lumen is not seen due to mucosal swelling. A small, 6 mm, paraintestinal lymph node is indicated as well. Here's an endoscopic view of the colon with multiple pseudopolyps. Here's an image of a patient with episcleritis associated with inflammatory bowel disease, showing the characteristic injection of the ciliary vessels. Here's an image of anterior uveitis, and a patient with inflammatory bowel disease is characterized by injection of the conjunctiva and opacity in the anterior chamber. That's all for the video. We'll see you next time.